Welcome everyone to this webinar. And this webinar is on preference studies in rheumatoid arthritis. Before we start the presentation and discussions on the content of actually two case studies about RA that we've conducted as part of this PREFER project, I would like to draw your attention on a few more housekeeping things. First of all, this webinar is being recorded and will be made public afterwards, and this regards only to the presentations. The Q&A session will not be posted online, and there will not be any personal information of participants posted online. You can find the webinar recordings via this YouTube link. I also must say that the studies presented here today were funded by IMI, and the presentations reflect the views of the presenters and not that of PREFER as a project, IMI, the European Union, or FPL. Now, should you have any specific questions about the PREFER project or about any of the case studies presented to you today, then please contact the PREFER consortium via the link on the screen, or contact, of course, any of the case study leads presenting today. So I already mentioned the word preferences, and before we start the discussion and the content of the case studies, I would like to provide you with some background information as to how preferences were defined in PREFER and also then within the two case studies presented today. Well, all of you know that all patients have wishes, needs, values, but certainly also preferences. And if I ask any of you how important the elements within this table are when you have to make a treatment-related decision, it's likely that you will respond like this. And of course, that makes perfect sense because all of these things are important when we make decisions. However, as researchers, we learn very little from this. Because we do not only want to know what elements matter, but we also want to know how much things matter. For instance, how much longer are patients willing to wait for a cheaper treatment? Or how much risks are patients willing to take for a treatment that is more effective? And this is what we mean with preferences. Today, there will be several speakers. We will start with a short clinical background introduction by Karim Raza. Then Karin Schölin Bywall will present a case study conducted in which we investigated preferences for second-line RA treatment. After that, Falahee will present a case study in PREFER in which we measured preferences for the prevention of RA. And then we have a short presentation on how we've involved patients in these case studies by Gwenda Simons and Eva Johansson. We will end the session with a question and answer part. Should you have any questions during the presentations of the case studies, then please post them in the chat. We will have this Q&A in the end where we can answer the questions that were put in the chat, or of course you are also allowed to unmute yourselves at that time and feel free to join the discussion at this session. So for now, I would like to introduce Karim Raza, who will provide an introduction to rheumatoid arthritis.
Okay, thanks, Ewan. I have to say it's been a massive pleasure for me to be involved with this IMI case study. I think probably quite a lot of people on the call are tuned into rheumatoid arthritis and what it is, but in case there are some people who aren't, as a group, we thought it would be helpful to just have 5 or 10 minutes at the beginning as an introduction to rheumatoid arthritis. And so that's what I'm going to cover. Next slide. So rheumatoid arthritis is quite common. It affects about 1 in 100 people. It's more common in women than men. And it's a disease, of course, of the joints, but the part of the joint which it actually is targeted in rheumatoid arthritis is the synovium. If you look at the cartoon on the left of the screen as you're looking at it, the synovium is the bit which I've circled in that with that black oval. And normally in people without inflammatory arthritis. Without rheumatoid arthritis, it's actually a really thin structure. It's maybe just a few cell layers thick. It functions to produce the normal lubricating fluid that helps the joint move. In people with rheumatoid, the synovium becomes really inflamed. And so if you look at that picture on the top right, that's a picture of the synovium of a patient with rheumatoid arthritis. Now that little bar that I've put there is about the thickness of a normal synovium. So if you then look at the synovium of someone with rheumatoid, you can see that it's massively thickened, massively inflamed. And what that translates to in terms of what a patient experiences is what you can see in the photograph of the hand. So the joints become swollen, and you can see the knuckles swollen there. The next slide. So of course I showed you a picture of a hand that was inflamed, but actually one of the main problems in patients with rheumatoid is that the disease spreads to multiple joints, and illustrated here are really the range of all the joints that can be affected in someone with rheumatoid. And when the joints are affected, they become painful, they become swollen, they become stiff, function becomes a problem, and patients feel very tired often as a result of the significant inflammation that they experience. So next slide. So of course that pain, swelling and stiffness is a major issue in its own right, but one of the complications we worry about as a result of long-standing active rheumatoid arthritis is that the joints can become damaged. And if you look at that middle panel there, there's an X-ray of the hand joints that I've illustrated. And if you look carefully at that X-ray, you can see there's two little upward pointing black arrows. And those little black arrows illustrate bits of the bone which have been nibbled away by that inflamed synovium. That synovium, which now is illustrated in that picture just below the X-ray, that inflamed synovium eats into and damages and destroys bone. And over time, if not really properly treated, rheumatoid can cause a lot of problems with the joints and a lot of damage and destruction, as illustrated in the photograph on the right. So next slide. So that's the joints. Actually, another problem in people with rheumatoid is that the inflammation can spill out of the joints and affect other bits of the body. One of the things that we particularly worry about is inflammation affecting the blood vessels. And so actually people with rheumatoid, particularly poorly controlled rheumatoid, can have heart disease. And in fact, some people have premature heart attacks as a result of poorly controlled rheumatoid. And the picture on the right, the X-ray on the right, is showing a collapse of a vertebra in the spine. And this kind of osteoporosis and fracture is another problem that people with rheumatoid can experience. Next slide. Fortunately, there's a lot that we can do to help manage rheumatoid arthritis as a disease. And a lot of what we can do has really, well, our new treatments, our new understanding about treatments has come about as a result of our understanding of mechanisms of disease in people with rheumatoid. So what's actually causing that inflammation? We have a good understanding now of the different types of cells which contribute to the inflammation. And as a result of that, a lot of new treatments have been developed which can target inflammation in people with rheumatoid. And that table below just illustrates a few of the many drugs we can use. Steroids, glucocorticoids on the left are cheap, quite widely used, but have quite a lot of side effects. Conventional disease-modifying drugs like methotrexate, also quite widely used. As we move to the right, we start encountering drugs which are even more effective, but actually very expensive. And the drugs in that last column, the JAK inhibitors, are a class of drug which you'll hear about a bit more in Karin's talk. Next slide. So over the last 20 years, there have been huge advances in treatments for rheumatoid, and the lives of millions of people have been transformed as a result of it. But there are issues with the treatments. The first is that all of the treatments are associated with potential side effects, some mild, but actually some potentially very severe. The treatments are troublesome in that most of them require regular monitoring. Some of them are taken via routes, which can, for some people anyway, be a bit of a nuisance. They have to be given by injection, or patients have to come into hospital for infusion. And some, particularly for the drugs towards the right-hand end of that table, the biologics and the JAK inhibitors, are actually very expensive. So next slide. So that's about rheumatoid. Karin's case study is going to focus on people's views about drugs to treat rheumatoid itself. But of course, ideally, we wouldn't want people to have rheumatoid. We want to be able to prevent people from getting rheumatoid in the first place. And the case study that Marie is going to present is focused around people's views on preventive treatments for rheumatoid. Now, in order for you to be able to prevent a disease like rheumatoid, you kind of need to understand the phases that people go through before they get rheumatoid, because if you're going to prevent it, then actually you're going to need to have to intervene in one of those at-risk phases. And over the last 10 years or so, we've developed a really good understanding of some of these at-risk phases, which this cartoon illustrates. So if you look at the far left-hand end of it, you've got someone who's actually completely well, but they may be exposed to risk factors for rheumatoid, including, for example, smoking or carry genes which put them at risk of rheumatoid. Some people at risk of rheumatoid then start developing antibodies in the blood associated with rheumatoid. They feel fine, they don't have any problems with their joints, but actually if you took a blood sample from them, you'd find that they had antibodies associated with rheumatoid in the blood. Some people then start developing joint pain, but no swelling. Then some people start developing a little bit of swelling, and then some people develop full-blown rheumatoid. So you can see there's those phases 1, 2, 3, 4, which are all phases which define individuals at risk, and actually you could potentially intervene in any of them to prevent someone getting to the far right-hand end of the cartoon journey, and that's what Marie will cover. So the next is actually my final slide, which is to say that although drugs to treat rheumatoid are really, really well developed now, there's many of them in widespread use in clinical practice, this prevention space is a newer one. There's a lot of studies going on at the moment looking at drugs to prevent rheumatoid arthritis. A lot of the drugs shown here are drugs that we use to treat rheumatoid, which we're looking at in at-risk phases to try and prevent rheumatoid. And so clearly it's important to try and understand what views of people who might receive these drugs are about preventive therapy. And I'm sure you'll enjoy hearing Marie speak about that. But I'll now ask Karin to advance, and by way of that, hand over to Karin, who works at Uppsala University, and who's going to talk to you about her case study.
Thank you very much, Karim. So, hi everybody, my name is Karin Schölin Bywall. I am a postdoc at Uppsala University. It's located in Sweden. And I will talk about patients' preferences for second-line rheumatoid arthritis treatment. And this is a study that we conducted in Sweden. So, just as Karim mentioned, patients with rheumatoid arthritis are facing several different treatment alternatives, and they are different in regard to how they are being administered and the effect of the treatment, but also the side effects. So within the study, we focused on assessing preferences for second-line treatment. And when we designed this preference study, we also consider the regulatory relevance of this study, because regulators, so decision makers that assess, makes the benefit risk assessment and whether a medical product should be approved or not, they want to include patients, and they are currently doing by including them as representatives in decision boards. But what they also want is that they want to be able to include data on a more aggregated level. So preference data assessed from the patients to be able to be included in the benefit risk assessment. So that's why we focused on this in this study. We had three main aims. The first one was to assess patient preferences for second-line treatment, but we also wanted to know whether there are differences in treatment preferences. And thirdly, we wanted to know if we could estimate the minimum acceptable benefit for a given side effect. So this preference study was a discrete choice experiment. So each respondent answered to 15 choice questions, and each choice questions consisted of 2 different treatment alternatives, so hypothetical treatment alternatives. And within those treatment alternatives, we included 7 different attributes with 3 levels each. So the attributes that we chose for this study was mode of administration with the levels tablet, injection, or drip, frequency of use, whether it's daily, weekly, or monthly taken. And we included the side effects attribute. So the probability of getting a mild short-term side effect, such as nausea, vomiting, or headache, the probability of a side effect affecting your appearance, such as hair loss, weight gain, or skin rash, and the probability of psychological side effects, such as anxiety, mood changes, depression, or sleep disturbance. And also probability of getting a severe side effect. And that was side effects such as getting a severe infection or allergic reaction. And when we chose the levels, so you see all of these side effect attributes have the same levels, we considered the package sleevelet, so the information that patients are already familiar with, but also information that is relevant for the regulatory decision makers. So information that they would use in a benefit risk assessment. And then we also included an attribute for the effectiveness of the treatment. Yes, so I have simplified this a little bit. In the patient preference assessment, we were able to include 358 patients in Sweden, and we recruited through clinics across Sweden. We also recruited through the patient association and their social media channels. And we also recruited through a company that recruit patients for you. And what we could see here is that we could find 3 latent or hidden preference patterns within the data. So 33% of the respondents thought effectiveness was the most important attribute out of those 7 that I just showed you. And 28% considered the administration, so how it's taken, or whether it's a pill or an injection or drip, as the most important attribute. And 38% considered severe side effects as the most important attribute. Yeah, so looking a little bit deeper into the different preference patterns, or the underlying preference patterns, we saw that those thinking that effectiveness was the most important attribute would also be accepting much higher side effects or risks of side effects than the other groups. Yeah, and looking a little bit deeper into the administration group, we saw that the probability of belonging to this group increased for those newly diagnosed. And then for the severe side effects group, we saw that the probability of belonging to this group increased for those with a longer disease duration of rheumatoid arthritis and already previous experience in mild side effects, such as nausea, vomiting, and headache. So this is the bigger picture here that I wanted to show you. So it was also other things that was important here. This is the 3 latent or hidden preference pattern in the form of a relative importance. So if we look at the second group, we see that the administration was the most important, but here those answering also consider how the medicine is taken as important, but also the risk of getting a psychological side effect. And we can see, if we look at the third group, that the risk of getting a severe side effect was most important, but it was also important the risk of getting a psychological side effect. So the clinical implications from this study is that we could see here that there were differences in what patients prefer, and it's important to acknowledge that from a clinical point that patients will actually like different things. And it's also important when you talk to patients to align their treatment decisions with their needs and their preferences. And the regulatory implications from this study was that we were able to provide data, preference data on an aggregated level in a relevant form to be used in regulatory benefit risk assessment. For regulators to be able to align their decision on whether to approve a medical product or not with the patient's needs and their preferences. Thank you. I would like to hand over to Marie.
Thank you so much, Karin. Hi, everyone. I'm a lecturer in behavioural rheumatology at the University of Birmingham, and it's a great pleasure to present some findings from our case study for PREFER. Next slide, please. So as Karim mentioned earlier, there's a growing interest in the idea of preventing RA by treating someone before they have developed full-blown symptoms of rheumatoid arthritis. So, sorry, can we go back to the previous slide? Thank you. So it's really important to understand the perspectives of everyone who might be affected by this approach. And this is something that we've been interested in for a number of years at the University of Birmingham as partners in several previous European consortia. So we've done a number of exploratory studies using focus groups and interview techniques, and also a survey to try and get a feel for all of these different groups, including people who are at risk or have an elevated risk of developing RA, such as first-degree relatives of RA patients and people who have symptoms or autoantibodies that are associated with RA development. Next slide, please. So one of the key themes that recurred across these previous studies was that there was a huge unmet need for informational resources for people about who is at risk of getting rheumatoid arthritis and what they might be able to do about it. And so in the Euroteam project, which I think you'll hear about again later on, we were lucky that we were able to work with an international team of patient research partners and clinicians and researchers to develop just that, some informational resources for people who might be wondering what their risk of getting rheumatoid arthritis is. And one of these, which was aimed at relatives of RA patients, has now been adopted by the National Rheumatoid Arthritis Society in the UK and is publicly available on their website. Next slide, please. So it made perfect sense for us as partners in PREFER to study the preferences for preventive treatments for rheumatoid arthritis, because we already had a lot of exploratory studies in this area, and it would be really nice to have a chance to quantify and really measure people's preferences for benefits and risks of aspects for preventive treatments. So we wanted to know what characteristics of treatments were important to people when they were making decisions about whether or not they would take a preventive treatment, and what level of what risks of side effects they would accept in exchange for a given treatment benefit. And we were also in the same way as Karin has just explained, we were interested in what kind of characteristics predict people's or different groups of people who have different preferences. And we also wanted to be able to assess what the likely uptake would be for preventive treatments for RA. So we designed a survey study. I'm not going to go into detail about how we did that here because it would just take too long. But it was informed by a previous qualitative study and also by a literature review, and also addressed lots of other methodological objectives, which I'm also not going to speak to. But if you are interested in that detail, then the study protocol is now published, and you can visit that after today for more information. Next slide, please. So our survey was completed by almost 1,000 people in each of 3 different European countries. So we had very large samples of the general population via online survey panels. And we also recruited first-degree relatives of RA patients via rheumatology clinics. So we asked patients or we invited them to ask their relatives if they would like to take part in our survey. And so we also recruited just over 350 first-degree relatives in the UK and also in Germany. Next slide, please. And all of the participants in our survey were asked to imagine that they were experiencing some joint pain and stiffness, and that they'd had a blood test and it showed that they had a 60% chance of developing RA in the next 2 years. And we asked them to imagine that their doctor has suggested that they might want to consider taking one of the following treatments for a year, and then asking them to choose between 2 different treatments, treatment A, treatment B, or to opt out, to have no treatment. Next slide, please. And this is an example of the kind of question that the participants in our survey answered. Each person actually answered 15 of this kind of question. And in the same way as we've just seen for Karin's study, each treatment option was described in terms of its level of several different treatment characteristics or attributes, including its effectiveness to reduce risk of RA, how it's taken, whether it was a pill or an injection or an infusion. Sorry, the slides keep jumping ahead of me. And also the risks of various side effects, including mild side effects, such as nausea, the chance of developing a serious infection that they could end up in hospital with, and also the risk of a serious side effect, such as developing lymphoma. Next slide, please. And so I'm going to go straight to some results. So this is results for the general population sample, and it's stratified by the 3 different countries that we looked at. So all in all, this is about just under 3,000 participants. And in all 3 countries, treatment was preferred over no treatment, and treatment effectiveness was the key driver of people's choices. But there were some differences across countries. In the sample in Romania were more sensitive to the chance of serious side effects and the chance of serious infection when they were making their choices. And they were also more likely to always choose no treatment. So almost 10% of the sample in Romania always chose no treatment. Next slide, please. And so we were able to assess the level of risk of each of the treatment risks that people would accept for a 40% reduction in their risk of getting RA. And in all 3 countries, participants accepted very little risk of very serious side effects and higher risks of serious infection, and even higher risks of very mild side effects. And there were some differences across the 3 countries. So in Germany, participants were much more accepting of a risk of serious infection than they were in Romania, for example. And there was a tendency for the sample in Romania to be less accepting of risk than in the other two countries. Next slide, please. So as I mentioned earlier, we also recruited a sample of first-degree relatives and wanted to compare the results for them with the results for the general public. And this is a summary of that. And you can see that the pattern of preferences was very similar in the sample of first-degree relatives as it was in the general population. The only really notable difference here is that first-degree relatives were much less bothered about how the treatment was taken, so whether it was a tablet or a drip or injection. And first-degree relatives accepted higher levels of risk numerically, but this wasn't statistically significant. So very similar results overall. Next slide, please. And like Karin, we were interested in the fact that different groups of people have different preferences. And in our analysis, we were able to identify 5 such groups with different patterns of preferences. And the participant characteristics that predicted which group a participant was most likely to belong to were measures of health literacy, reported numeracy, perceived risk of developing RA, and also people's beliefs about RA, so how seriously it would impact on them if they were to develop RA and how effective their treatment would be if they were to develop RA. Also their beliefs about taking medicines in general, and also which country they were in. Next slide, please. So we also included an additional choice task in our survey, as well as the ones that I've seen you, where we asked people to choose between 4 different treatments to opt out. And these treatments are based on the drugs that are mostly currently being used to treat RA, but are being investigated for their effectiveness to reduce risk in people who are at risk. So they haven't known side effects and characteristics, but we asked the researchers who are leading prevention trials for RA to help us estimate their effectiveness to reduce risk of RA. So these treatments are intended to reflect the kinds of treatments that are currently being investigated to see if they can reduce people's risk. And we asked people to choose between them, and you can see that the least popular choice was no treatment. Most people chose one of the 4 preventive treatment options. Next slide, please. So to summarize some key conclusions, effective treatments to prevent RA were acceptable to most people who were asked to assume that they had a high chance of developing RA in the next 2 years. And we were able to identify different groups of people who were likely to have different preferences, and we were able to explain some of that variability with participant characteristics such as health literacy and numeracy and so on. Now, we asked people to imagine that they are at risk of developing RA, but what we really want to do next is to do a similar kind of study with people who really are at a high risk of developing RA. So, for example, people who have symptoms such as arthralgia or joint pain that indicate they have a high risk of developing rheumatoid arthritis in the future. So that's some further research that needs to be done in this area. So I think that's my final slide. Next slide. So it's a great pleasure to hand over to my colleague, Gwenda Simons, who is a postdoc at the University of Birmingham, and also one of our excellent patient research partners, Eva Johansson, to tell us about how patients were involved in our case studies. Thank you.
Thank you very much, Marie. So yeah, I'll just be very briefly going to talk to you about patient involvement in both the RA case studies that we have heard of today. Before I'll be handing over to Eva, who can tell you much more what it is like to be a patient research partner and how, what the kind of things that she and others have been involved in. Could we advance to the next slide, please? So I'll start off with giving you a little bit of a flavor for the patient involvement in Karin, in the study that Karin has just described to us, the preferences for second-line RA treatment. In her study, she worked together with 2 Swedish patient research partners, both of whom have got rheumatoid arthritis. And they were involved in a selection and description of the treatment attributes and levels, the factors that affect the choices, preferences for treatment. The meetings to validate the selection of these attributes, the development of the educational material used in the survey, as well as the pre-testing of the survey, so the pilot of the survey, and analysis and interpretation of the results of the various phases of the study. Next slide, please. Then there's also been patient involvement in the preferences for treatments to prevent RA, the study that Maria has just described to us. And in this study, we worked together with 8 patient research partners from the UK, Germany, Netherlands, and Sweden, who all have RA. So a truly international team of patient research partners reflecting the international nature of our study. And they were involved in the development of the clinical aims of the case study. So we go way back with patient involvement. So the first aspects of the study, the clinical aims were developed together with patient research partners. They're also involved in the design and the content of the questions for the focus group schedule, so the qualitative study that Marie mentions, the analysis and interpretation, as well as the write-up of these focus group results. They also advised us on how to recruit first-degree relatives to the studies, and they also voiced some ethical concerns in relation to this, which we were able to address. And then the selection and description of the treatment attributes, very much like in Karin's study, and then the survey content, so how everything was presented, as well as what kind of information about rheumatoid arthritis, for example, to convey. The pre-testing of the survey, again, like a pilot, but then also they have been involved in tasks such as giving feedback on presentation slides for this presentation, but also other presentations we've given in the past. There are co-authors on the lay summary that I've been told is very recently being published, and some of them have been involved in writing of prefer recommendations, or are currently involved. And next slide, please. So I would like to hand over to Eva, who's going to be able to give you a much better idea of what patient involvement actually is, and talk a little bit about her experiences. So I'm going to stop my video now and hand over to you, Eva.
Thank you, Gwenda. So hi, everyone. I'm a patient research partner from the Swedish Rheumatism Association, and I have 30 years of lived experience with RA. I work with the Birmingham team, and I had the pleasure of working with Karim and Marie and Gwenda in Euroteam in 2013. And the Prefer PRPs Di Skengel and Sue Thomas were also part of Euroteam. And I'm currently working with PRPs Margot Backish, Tom Esterine, and Ruth Williams in another IMI project called Are the Cure. So this slide then, what would a study on patient preference be without the input from patient representatives? The input from patient research partners takes many forms. We ask questions, we take part in discussions, these questions often lead to discussions, give feedback on texts and presentations. We analyze and sometimes challenge interpretations of data, and also co-write both academic and lay texts. Next slide, please, Julie. So these are 3 examples from Gwenda's list. And in the focus groups and interviews, we gave feedback on and took part in discussions of the focus group scenarios and questions, the information and the setup of the focus groups. We gave insights in how to describe RA to a healthy person. We provided our views on ranking treatment factors. We provided feedback on the collected data by giving a patient angle on the analysis and interpretation of quotes, and challenged some choices of content and categories. Discussion of the focus group data also resulted in the risk stipulation being changed from 40% to 60% risk of developing RA for the survey. Next slide, please. So in the survey, the discussions on the content of the survey started very early during the focus group stage already. And we gave feedback on content, structure, questions, phrasing and language of the survey, as well as tested it online. And then the last point, number 3, the lay summary, the recommendations, prefers recommendations. We worked on chapter 4, and the paper of qualitative data. The feedback was given on content and how to present results, as well as on all the aspects of text and writing, at times merging into co-writing. Thank you.